Our next presentation, our fellow in nuclear medicine, Daniella Pinho. Her mentor is Dr. Dana Matthews, and the title of her presentation is FDG PET-CT Imaging Protocol for Head and Neck Cancer. Is abdominal and pelvic imaging needed? Thank you, Dr. Pinho.
Good afternoon. So the FDG PET-CT is widely used in patients with squamous cell carcinoma of the head and neck, and some of the indications include the search for an unknown primary in the patients with cervical lymphadenopathy, also in newly diagnosed tumors for better local staging, and to search for metastatic disease, and also to look for second primary malignancies. And is also used to assess response to treatment in these patients and to evaluate the recurrence of tumor. And the standard protocol for PET-CT in these patients include an acquisition from the midbrain to the mid-thigh. However, there is little data supporting that we need this abdomen and pelvis coverage. So the incidence of distant metastatic disease in these patients is reported in the range of 4 to 26%. And the most common site are the lungs. So our hypothesis is that we can eliminate the abdomen and pelvis acquisition from the PET-CT studies performed in these patients, given that there is a low incidence of metastatic disease in these locations. And our purpose was to determine the incidence of metastatic disease in the abdomen and pelvis in these patients, and that we can see with this extended abdominal and pelvic coverage obtained in our standard PET-CT protocol. Excuse me. So this was a retrospective, IRB-approved and HIPAA-compliant study, and we evaluated the reports of the PET-CTs in patients with a squamous cell carcinoma of the head and neck for the findings in the abdomen and the pelvis. And we classified the findings in 3 categories: metastatic disease, indeterminate findings, which we could not say at the time of reading, and also other non-related significant findings in the abdomen and pelvis. The demographics and the primary tumor characteristics were also noted. So we had a total of 154 patients, majority of males, and also more than half of the patients had either a moderate or a poorly differentiated tumor. So for the primary tumor location, we had 6% in the nasal cavity, 30% in the oral cavity, 42% in the oropharynx, 3% in the salivary glands, 12% in the larynx, 4% in the hypopharynx, and 4% of primary unknown tumors. All of this is squamous cell carcinomas. So we had 16 patients had indeterminate findings in the abdomen and 4 patients in the pelvis. So this is an example of one of our patients that had this hypodense lesion in the liver, which had no FDG uptake. And this lesion was stable in a follow-up PET-CT 7 months later, likely not representing a metastatic lesion. This other patient had this small focus of increased uptake in the liver, which didn't have any CT correlation. And it also resolved on the follow-up study, so likely not a metastasis. This patient had this soft tissue density with some calcifications in the pelvis with a low level FDG uptake, which was probably related to post-surgical changes. So for the other significant findings, we had 3 patients that had in the abdomen and 2 in the pelvis. So this is an example of this patient that had an obstructive stone in the right distal ureter, determining this moderate hydronephrosis in the right, which was an incidental finding of this study. And this patient had this FDG-avid asymmetric thickening in the rectal wall, which was proven to be an adenocarcinoma in a follow-up biopsy. It was also an incidental finding. So we had a total of 9 patients with distant metastases with different primary locations and histologic grade. However, we noticed that all the patients were follow-up studies after treatment, and also all these patients had stage 4 tumor at initial presentation. We had, from these 9 patients with distant metastatic disease, we had 1 patient with a metastasis in the abdomen, which had a lesion in the liver, more than 1 lesion in the liver, and the other patient that had metastatic disease in the pelvis, which had a lesion in the left ischium. And we also noticed that both these patients also had concomitant metastases in the lungs. So this was our the patient with metastasis in the abdomen, in which we see this FDG-avid lesion in the liver. And as we can see on the image, so here was the metastasis in the liver, and we can see here he also had this FDG-avid lymph node in the mediastinum, which was also metastatic. This is the patient with metastasis in the pelvis. We see this FDG-avid lesion in the left ischium. And this patient also had this small FDG-avid nodule in the lung, which also grew after and was biopsy-proven tumor. So as an overview of our results, we have 154 patients with a total incidence of metastasis of 5.8%. And when we consider only the abdomen and pelvis, we had an incidence of 1.3% of metastatic disease. Again, both the patients also had non-lung mets at the time of this study. And these are all follow-up patients doing it after treatment and had a stage 4 tumor at initial presentation. We saw a low incidence of distant metastatic disease in our study group, which matches the reported incidence in literature. And we also know that when we are including the whole body on our PET-CT protocol, we are having a high radiation dose, longer scanner time, more time for the radiologist to spend reading the non-related findings, which all result in an increased cost for the study. None of our indeterminate findings were proven to represent mets in the follow-up studies, and this probably generated some unnecessary follow-up studies and patient anxiety. Some of the limitations of our study, it was a retrospective study, not a prospective one, and also our sample size could be larger. And the study length, we had a 7-month period, and we followed these patients for about a year after that. So we didn't have follow-up for all the patients. And it was also restricted only to squamous cell carcinomas. So in conclusion, based on our results, we think we can eliminate the acquisition of the abdomen and pelvis from our PET-CT studies in the patients for at initial presentation of squamous cell carcinoma of the head and neck. And also, it could also be eliminated in the follow-up studies for patients that had an early stage tumor at initial presentation. Thank you.
Questions for Dr. Pinho? Yes, Dr. Surmain.
One of the key factors in how metastases appear in head and neck cancer is not only the stage that you talk about, the other one is the HPV status of the cancer, especially for the oropharyngeal cancers. So have you looked at that in this cohort?
Sorry, can you repeat that?
The oropharyngeal cancers, the HPV status, those patients with HPV positive disease have a more tendency to go beyond the lung. So have you looked at that?
Yeah, we look at that. We didn't have that information for I don't remember the number, but it was not for a significant part of the patients that we had that information. So when we tried to correlate that, it was not enough number of patients with that information.
Second question is, this has been shown in other studies before, so why we haven't changed the practice is, now if you think about it, the whole body scan takes only 12 minutes, and the radiation dose is not significantly different because we have already given the FDG dose to the patient, so it's a whole body radiation. Only radiation that you're saving is just the abdomen and pelvis low dose CT. So that may have some, it's a minimal amount of radiation, and also you're not going to save more than, I would say, 5 minutes in the scanning time.
I think one of the reasons that we did this study is that we felt that we were spending a lot of time with all these non-related findings in the abdomen, and we were putting a lot of time and effort looking at all these images and not getting, much useful information. So I think this was one of the main things that, made us do this study. And also, the radiation dose savings, I agree, it's not that big, but still we were saving some radiation. And I think the radiology, the nuclear medicine physician that is evaluating the studies, spending less time with this non-related findings than in the lesion itself.
Daniella, can you clarify that highlighted statement in the last slide? I'm not sure am I missing something? How could you not miss metastasis in the abdomen and pelvis if you never scanned them? Or do you mean to say you would not have missed metastatic disease?
No, the thing that I try to say here, Dr. Rowski, is that, so what we are proposing is that at initial staging, we didn't see any metastases in the abdomen and pelvis. When patient came for baseline study, initial staging, we didn't see any mets. So if we don't perform the abdomen and pelvis in these patients, we are not missing any metastatic lesion. And for the follow-up studies, for the patients that had an initial early stage tumor, like stage 1 or 2, that go through treatment and then they have a follow-up scan, none of these patients show any metastases in the abdomen and pelvis. We are not excluding the chest here, because most of these patients had metastases in the lungs. So what we are proposing is to not acquire the abdomen and pelvis in patients with initial baseline studies and also the follow-up studies for patients that had an initial early stage disease.
Okay, and then one last question is, why do you think the initial slide portrayed a much higher incidence of metastatic disease? Why do you think your results differ so greatly?
Well, they reported in the range of 4 to 26%, and the literature review that I did, it depends on the stage of the patient. So some of the studies were done in advanced stage tumors and reported an incidence of 20%, probably stage 4, 3, 4. So I think that's why it varies so much on literature, but I think our results are still within that range because it was for 4 to 26%.
Would that make you modify the patient population that you would make this recommendation for, or you just say across the board, throw out the abdomen and pelvis?
Well, I think this will be, I think we would do that only for the patients that have early stage tumor, not acquire the abdomen and pelvis for patients with early stage tumors. For the advanced stage, I think I agree that we still need to have it.
Thank you very much.
Thank you.